Hello, everyone. We are very, very pleased to launch our Metabolic Masterclass, MMC. And the topic that we have chosen for this session is obesity. People may not realize how important this problem is, how big of a pandemic this is, even more than the pandemic we are facing right now. And it's our pleasure as graduates from MMC to gather, discuss a little bit, and maybe hopefully educate the listeners and prod you all to think a little bit more, maybe differently than what you've been thinking so far. Okay, so before we go into the topics, I want all the participants, the speakers to introduce themselves. Let me introduce myself. I am Dr.Kavya M.D, and I graduated from MMC. We all belong to the 2002 batch of MMC. And after that, I got a privilege to do MD anesthesia there, but I'm in the United States, and since we moved here, I have done another MD in internal medicine, and I'm also board certified in obesity medicine, which makes this a very important and personal topic for me. I'm excited to hear from our speakers what they have to share, because we all come from different places, we serve different communities, and still the pandemic holds.
Thank you, Kavya, for getting us all together in this meeting. It's a pleasure to be back with friends discussing about a very important topic that is very relevant to today's time. I'm Ravi Shanker. I'm a consultant in Singapore General Hospital and an assistant professor with the Duke NUS Graduate Medical School. I'm a gastroenterologist by training. I completed my undergraduation with all my friends as here in Madras Medical College. Then I did my internal medicine training in Singapore and then completed my GI fellowship in Singapore. One of the things that has been fascinating me is how to help patients with obesity and offer them a spectrum of treatment. And that led me to do my additional training in endoscopic management of obesity. I'm also a certified specialist by the World Obesity Federation, and it again gives me a pleasure to share different facets of treatment for obesity care. And it's always fun to be back with friends when we are meeting 20 years later. I'm more excited to discuss and learn from my friends. And thank you again for having me.
Okay.
Hello, friends. This is Dr. Thangadurai, general and laparoscopic surgeon with 8+ years of experience. I have recently quit my surgical practice and fully into the metabolic health, because I had some insights that there is some lacuna in clinical nutrition and our understanding in metabolic health. So we recently started a company called Dr. Gold Healthcare, which is more into the metabolic health.
Thank you, friends. It's a real pleasure to join with all of you and to see you all after 14 years. And still I can see all of us remain the same by heart. And I'm Dr. Padmarani. I completed my MD Physical Medicine and Rehabilitation from MMC and diploma in the same specialty, physical medicine and rehabilitation, and fellowship in interventional pain management. And I'm here in Tamil Nadu Government Medical Service since 2011, and I have completed 10 years of my service here. Right now working as assistant professor in the Department of PMR, Government Pudukkottai Medical College. And the topic of obesity, it is a real issue of concern in all age groups throughout the world, which has to be dealt cautiously and also meticulously at the right point, so that it is one of the primarily modifiable risk factor for many other diseases that has to be considered. And being a rehabilitation physician, I would like to convey my views regarding the rehabilitation of the lifestyle and exercise prescriptions with respect to obesity management. And also I can contribute to the other views if I can. Thank you.
So getting on to the topic. So obesity, the pandemic that is still on, like we said. So this is a gist of what the prevalence of obesity is like now. This is the data from WHO. Worldwide, obesity has nearly tripled since 1975. 2016, more than 1.9 billion adults 18 years or older were overweight. And of these, 650 million were obese. 39% of adults age 18 or over were overweight in 2016, and 13% were obese. This is 2016 data. We don't have the most updated data, which is probably much worse than this. And most of the world's population live in countries where overweight and obesity kills more people than underweight. So we worry about people dying of malnutrition and underweight. This kills more than people who are malnourished. 39 million children under the age of 5 were overweight or obese in 2020, and over 340 million children and adolescents aged 5 to 19 were overweight or obese in 2016. So that's the problem that we are talking about. So first of all, what is obesity? How do you define obesity?
I think we need to keep it simple for people to understand. Obesity is just, in a way, in a layman's word, if I were to say, is excess accumulation of fat, where this excess accumulation of fat poses significant health risk to the individual. So by health risk, what I mean is, it can be anything. It can be like an increased risk of you developing diabetes, you getting hypertension, sleep apnea, in females having PCOS, arthritis, and in fact, in even having a poor quality of life. So excess amount of fat accumulated over a period of time that poses significant health risk should be considered as obesity, to keep it as simple for people to understand.
Obesity is actually a red herring because it is a misleading clue. The real big problem is metabolic syndrome, the common denominator being the insulin resistance. Because the obesity cannot be defined in a uniform way because the ethnicity differs, right? Like in the West, they have a very good fat threshold in which they can put on weight without developing metabolic syndrome, maybe in a later age. But when compared to the Asians, who live in the tropical near the equator, there is no need for a very good fat storage. It is a human evolution. They need to store fat, but we don't have to, because there is a lush of vegetation around the year for countries near the equator. And it should not be just extrapolated as increased cardiovascular and metabolic risk factor for Asians. And with respect to genetic, there is an entity called personal fat threshold, which means the personal fat threshold is determined by the genes in which the person can put on weight. The fat cells can grow in two levels. There is hyperplasia and hypertrophy. Whenever the fat cells grows in hyperplasia, there is absolute insulin sensitivity. Whenever the fat cells grow with hypertrophy, then the problem arises. It can reach a level of 15 times its original size. But beyond this, the problem happens. The fat spillover occurs and the entire metabolic syndrome set in.
I want to ask a question to Thangadurai. Do you mean to say that metabolic syndrome occurs in all those who are obese? Which means obesity doesn't sit without metabolic syndrome?
Yeah. Around 80% of obese and overweight populations are having some or any component of the metabolic syndrome, whereas around 40% of normal weight or even lean patients are even having metabolic syndrome. That's what I'm telling. The obesity is actually the tip of the iceberg. The real problem is the metabolic syndrome, the common denominator being the insulin resistance.
So we can define obesity on a metabolic way. Do we have any other way of defining obesity?
Yes, I think a more simpler, like said, for people to easily understand. We do have not the perfect measures to define obesity. There are ways to measure obesity with BMI, for example. Worldwide, a BMI, which is nothing but a ratio calculated based on your height and the proportionate weight. If you have a BMI more than 30, it's considered obesity for the most part of the world. But for people in the East Asian region, a BMI of 27 or higher is even considered obesity. And the same people, normal BMI is between 19 and 25. So anyone who has a BMI between 25 and 30, they're considered to be in the overweight category. And the same with the Asian population, between 24 and 27, they would be considered to be overweight. Another measure is to do the waist circumference. So our waist to hip ratio, those are other measures, which are maybe more easy to perceive, but not the perfect, obviously.
I think it's these are good points raised by Kavya, because when we talk about addressing people with obesity, we need to have realistic, simple to use tools in clinics or in practice. Well, BMI may not be the best measure, but that's what is easy to measure by the bedside. Somebody who is muscular may have a higher BMI, but that doesn't mean that that patient is obese. So in situations where we are confused to brand somebody as obese or not, then we can use a combination of measurements. You can use BMI and then add waist circumference to it. More important is in practice, we need to know the prevalence of the population or the type of ethnicity that we have. In some countries, maybe in the United States, there is going to be a mix of population. So you need to really know what applies to who. One point which Kavya raised was very important. There is going to be a difference in the risk in terms of getting metabolic illnesses based on BMI. For instance, if we take a Western population, Western world, a Caucasian male with a BMI more than 30, that's when we call it as obesity. But in Asia, it's completely different. Somebody as low as BMI more than 25, you may start seeing them having manifestations of diabetes, manifestation with hypertension, or even their mortality rate goes up. So there is going to be a contrast between the East and West. So applying this Western template to an Asian population may not be appropriate and may not be ideal. So we need to know what cutoffs to use to guide our treatment plans so that we can advise these patients. One of the reasons, I think Thangadurai would be able to explain it better, the reason why we see this disparity between the East and West is the way the fat distribution is. We call it as like thin outside and fat inside. Asians are having a thin body frame, but you see the distribution of fat is predominantly visceral. Their abdominal circumference is all much more bigger than a Western male with a BMI more than 30. In fact, studies done comparing East and West, adjusting for their smoking, actually has shown at a lower BMI, people develop cardiac risks or even have an early mortality in the Asian population compared to the West at low BMI. So I think when we see patients of different ethnicities, the cutoff should also vary, and our counseling and discussion with this patient should differ.
Again, there is a gender difference between males and females that is not being taken into account these days. In males, what we call the android obesity are apple-shaped, right? And then females, pear-shaped, which is more or less what we think is in females, the estrogen as well as the progesterone causes fat cell hyperplasia, whereas in males, who are having higher risk because the fat goes by hypertrophy predominantly. So in premenopausal age groups, the women are having a better metabolic advantage because the fat actually deposits in the gluteofemoral region, that is more of the subcutaneous fat. Whereas for the same amount of fat that has to be deposited for males is in the visceral area. That is again causing the insulin resistance.
That's true. Fat distribution. I hope you're able to see this picture, like how it is distributed also plays a big role, and not just the presence of fat itself.
And again, in the post-menopausal age group, the women have a higher risk because they lose the hormonal advantage, and they again develop the android obesity in post-menopausal women. That is having a higher cardiovascular risk factors.
I think these are all very important and relevant points. But one thing which we notice in clinical practice is among population who are obese, the number of frequency at which these patients actually come to a clinic to see consult is in fact not that frequent, I would say. I would say most patients, in fact, delay consultation for obesity management. In fact, it's at least like 6 to 7 years. And the time they actually present to your clinic is they already have a metabolic complication. So how do you guys think we should encourage our patients to actually seek consult earlier? Because there is a lot of weight stigma around coming from obesity clinic. Not many people actually find it comfortable to discuss about weight. So how do you guys tackle this problem in your clinical practice?
So I think that is a very important question. The minute we start branding it as obesity, there's a lot of stigma to it. So that is why it's important for every physician, every provider to be equipped to handle this problem, and is not just a specialty thing. With the prevalence of obesity being the way it is right now, every other patient or every third patient you're seeing is going to have obesity and the complications of it. So every physician should be equipped to handle this. And I hope that this is like a little beginning for that. And we should all be able to use words that are friendly to our patients. In the obesity world, there is language that's very important, because once you call them obese, for example, they say that you're describing a history of a patient, and you say, this is a 41-year-old male who has obesity, versus you're saying 41-year-old obese male, making that as an adjective versus making that as a problem that they're dealing with makes all the difference. So definitely we have to work to reduce the stigma around this problem. While this is a problem on one side, there is a whole group of people who are metabolically healthy, but they're craving towards even more and more weight loss in an unhealthy manner. So we have to really educate the community on like what healthy weight is, and what is appropriate, what is acceptable, and also to educate them that it's not always their problem. That's something that people take on themselves, like they feel like it's that something that they do. It's not necessarily what they do. There is a lot of damage that has been done internally as well as externally. This is contributing to this pandemic. I think Thangadurai has a lot to say about that, about why now, right? Like we read that from 1975, it has tripled in just 30, 40 years.
Yes. Actually, we are also blaming these obese patients, telling like gluttony and sloth results to obesity. It's not, it's actually the other way around because of the decreased metabolic rate, which is seen in insulin resistance. And in the last 40 to 50 years, there is a drastic change in the metabolism that occurs in the human race. There is actually a discrepancy between the human evolution, right, and the ultra processing of foods. Actually, a disconnect between the human biology, which has evolved over thousands and millions of years, and the recent use of the ultra processed food. The very simple reason being the insulin is the predominant factor in the etiology of obesity. Hyperinsulinemia often develops in more than 75 to 90% of the population. So it is almost the normalcy. We are always looking at normalcy. It is not actually the case. The hyperinsulinemia is not actually normal. Hyperinsulinemia often leads to the fat storage, increased fat storage, and decreased metabolic rate. So what we are having today is following the sad American diet, that is the Western diet, which is actually a 50% fat and 50% carbohydrate. It is actually the same thing that is used in the standard obesogenic chow in rat models. So we need to have a better understanding in the macro and micronutrients for preventing obesity as well. The insulin, whenever there is higher insulin or hyperinsulinemia, it always favors the fat storage. And we are eating muffins every 2 hours to stay alive. It should not be the way. There should be a periodical fasting as well as feasting. We are eating like kings and queens all throughout the day, right from the morning till midnight, and are even having snack at the midnight, right? So from morning to midnight, there is a hyperinsulinemia. It should not be the way. Actually, people before 40 to 50 years, they used to have only 2 meals a day. And we are having 3 to 4 meals a day, along with 2 to 3 types of snacking in between. So whenever we snack, there is a increased insulin response, just because of the refined carbs and fats. So always the insulin stays high above the baseline. This is the major reason why, because we are obese.
Okay,
I think one of the I partly agree with what you say, but I also disagree with certain things that you have raised. Importantly, it's not just about eat less and move more. It's sometimes easy to put it across to the patient as you just keep eating and that's why you're fat. Don't come to me, don't bother me because the problem is with you. I think that is one of the biggest bias which actually as physicians that we do sometimes. In fact, many of my friends who I have seen practicing across, whenever they encounter patients in clinics, the first thing they say, "Hey, you're just fat. Stop eating. Stop. Put on your boots and start running." No, this is the advice which is being given, and time and again we know that this kind of advice never works. It has never worked. The second time you repeat the same statement to the patient, that's the last time you're seeing that patient in your clinic. The patient is not going to come back again to you because this kind of advice is not going to work. What we rather need to do is to actually identify what is that makes our patients to choose this track. More importantly, it's actually understanding the physiology or even trying to phenotype these patients so that we can guide our treatment rather better, rather than just saying, well, it's calorie excess and then you're not burning it off. But it's not always like all patients do it out of purpose. There are going to be many reasons. That's the reason they actually come to see us. We may need to sit down, identify the root cause, develop a plan, um, find areas where we can improve for the patient. It's going to be a lot more than just eat less and move more. We have to identify behaviors. We need to stick to the 4 pillars of obesity care, and then I think that is what would help the patients long term, rather than giving a piece of advice which neither works or it works only in short term.
Yeah, I totally agree. Actually, the habit of eating less and moving more never works. But we should eat right and also fast in between. There is actually a hijacking of the American minds because of the increased dopamine, which is a reward, and also it's a cause of addiction. The ultra-processed food actually has screwed up the hunger and satiety center, to be honest. There is a trifecta called sugars, increased sugars, refined things, and then refined fat as well, right? All these things screw up the hunger and satiety signal. We never know, how many of us know what is a true hunger and what is an emotional eating and what is satiety in the world of ultra-processed foods. So we need to move away from the ultra-processed food. We need to eat according to our hunger, right? This is the way we should go, I think.
So that brings an interesting point for discussion. I personally have always heard and maybe kind of agree also that frequent small meals decrease the postprandial rise of glucose rather than eating two big meals. So what you're bringing up is eating throughout the day keeps you at a high insulin level throughout the day. So do you say that hyperinsulinemia is mainly because of how you eat, or is there another trigger for why hyperinsulinemia sets in the first place?
Yeah, hyperinsulinemia is mainly due to the ultra-processing of food. What happens is that maybe 40 years ago, before the Green Revolution, before the introduction of the hybrid rice varieties and wheat, what we usually have is the traditional grain variety in which there is very good amount of fibers along with very good fat in it, along with the minerals as well, which also is important because these minerals and vitamins embedded in these grains very well is acting as a cofactor for their metabolism, right? So when we strip off all the nutrients, all the fibers, and just leaving alone the starch, then the problem arises. There is actually a micronutrient depletion that happens with ultra-processing of foods. That again leads on to the insulin resistance at a cellular level. And this also is an very important thing that leads on to obesity, that favors the fat storage. Because what the real food is, it has to be hepatoprotective, and what the real food is, it has to be actually hepatoprotective, and also it should feed the microbiome. And what we are really eating nowadays is it's not feeding the microbiome at all. We are feeding the ultra-processed food that is digested in the early part of the small intestine. And the satiety signal is never reached because there is a lot of satiety signal in the distal ileum as well as in the proximal small intestine. But the satiety signal never reaches our brain because all the ultra-processed foods are not even digested. They are actually directly absorbed very easily into the bloodstream. So there is actually a rush in glucose levels. When we consider the traditional grains as well as the ultra-processed food, the amount of carbohydrate in each one of these is essentially the same, but the fiber holds it and there is a slow absorption that is not a very good, that is not actually, what to say is, the pancreas never need to work hard for this because there is a smooth metabolism. And this is actually a signal. When there is a lot of glucose rushing in at a specific level within 45 minutes to 1 hour, then the pancreas has to work hard, producing more insulin level, pushing the glucose in because it always normalizes the glucose at a certain level.
I think I can understand a little bit. Okay, so the topic of
I think,
obesity.
in a way, what we need to pass on to the audience is how do we phenotype these patients when we see in the clinic. So, not every patient fits into one template. So, if we broadly classify, yes, it is about energy intake and energy expenditure. But let's look deep into energy intake. So when we talk about energy intake, we are gonna have people who take big meals. There are gonna be people who are gonna have frequent meals, and there are gonna be people who are gonna have emotional eating. And then lastly, we are gonna have people who we so-called call as slow burners. These are the simplistic classification that we can employ, although identifying these patients just based on history alone might be difficult without ancillary tests. But let's try to understand what each component here means. So let's talk about a patients who eat big meal. What does this actually mean? In hunger pathways, there are two important concepts that we need to know. One is satiation and satiety. What is satiation? Is the sense of feeling full, and satiety is like the duration that you feel full. So these are something which we need to understand, and a lot more hormones and physiology plays into this in terms of meal consumption and then leading to obesity. So the number one is a patient who has a problem with meal. So how do we know? This patient always says that I can eat as much as I want, even beyond my sense of fullness. So here satiation is going to be an issue. In which case, if we want to address this group of patients, then you need to target diet which makes them feel full so quickly, which we need wherein we really need good nutritionists to help us plan diet to induce satiation, or even we may have to complement with drugs that acts in the hunger centers, satiation centers to induce satiety. The second group of patients are the ones who say, I eat, I within 1 hour or two, I again feel hungry. I have to eat again, and then I have to eat again. So what it actually means here is there is a sense of fullness, but the fullness only lasts for a short duration of time. And then there again, the stretch receptors in the stomach, the hormone levels within the stomach is kind of like going to vary so differently that they feel hungry again. In essence, what it means is the stomach is emptying very fast, which means the gastric emptying here is going to be very fast. So what do I tackle in this group of patients is you're going to prescribe a different kind of diet, which kind of like slows the emptying of the stomach. At the same time, helps promote release of some of the hormones from the distal small intestine that further slows the emptying of the stomach. So all of us would know that there are certain drugs which are used in obesity treatment like liraglutide and so on. It functions in the same way to help these patients by slowing the emptying of the stomach. And the third group of eating is patients who, whether they are sad, whether they are happy, these are like emotional eaters. It's more for behavior related issues. So whenever they have a happy moment in their life, they have to eat. They have to eat calorie dense food. Whenever they feel sad, whenever something wrong has happened, then they resort to eating. So this is going to be a behavior issue where we really need the help of behavior psychologists to sit with them, develop cognitive behavioral, in fact, come up with a cognitive behavioral therapy plan to assist these patients in changing their behavior. The last group of patients is going to be the slow burners, wherein their metabolism is slow. Whatever they eat, they burn 10 to 20% less, which in other words mean that they are storing 10 to 20% extra energy. And then if this continues to go on for a long period of time, they're going to even accumulate more and more and more calories, which gets excess glucose always gets converted into fat, and then that fat increases your leptin levels, which leptin levels in fact causes insulin resistance. So the spiral continues, and then the patient tends to accumulate weight. So in this group of patients who are considered as slow burners, then the treatment plan is going to be like completely different. You're going to like make them burn more by involving them in physical activities, or where in fact resistance training plays an important role, and sometimes even drugs to stimulate burning. So I think diet exactly is one important component, but deciding or phenotyping our patients into these different classes, and then planning our treatment according to their phenotypes is what is going to cause a lot more success. In other words, planning our diet is also important in terms of taking into account the calorie density of the food that we give, the property of the food in terms of its effect on gut hormones and emptying, that is more important. And lastly, we should also utilize the thermogenic effect of food in terms of calorie burn. So it works well when we have the right people involved in deciding what suits the patient best. But even more important is we need to profile our patients properly. We need to phenotype our patients properly to maximize the effect. One another important point which I often encounter is managing patients' expectations. Sometimes patients come to us looking for results or instant results. How do you handle these issues? How do we ensure, how do we tell our patients that, you know, you are here for a long haul? We are not here for a short trip, because obesity management is going to be managing a chronic disease, and it's not going to be something see me once and say bye-bye. So how do you address this issue?
That was very well said, Ravi. Thank you for taking your time to explain those things. Yes, before I get to your question, because we talked a lot about energy intake, I want to get Padma's opinion on energy expenditure. When we talk about how much the pandemic has become more prevalent now, along with probably processing of foods, the kind of diet, that it's also important that our lifestyles have become more and more sedentary, and that is a huge contributor to why it is at a level where it is right now. So coming to the lifestyle aspect of it, coming to the energy expenditure aspect of it, so I want to hear from you, Padma, regarding how much you think that the sedentary lifestyle has been contributing to this problem. I think she's not here. Maybe we can come back to your Padma. Are you there?
Am I audible, Kavya?
Yes.
Yes,
Now,
of course.
I think I have some issue with my laptop. I'm not able to view it properly, but hope I am best heard.
yeah, we can
Yeah,
hear.
you can proceed. Yeah, you can proceed with that.
Yeah, really the sedentary lifestyle definitely has a big impact on the obesity, especially in the community of people here, that too in adults and adolescents, those who are frequently using computers, laptops for their online classes, especially during the lockdown and
Yes, she's right. I couldn't hear her. She's gone.
Gone.
So, Okay. I think, yeah, so coming back to your point, Ravi, about how you said, how are we going to manage the patient expectations? That's a huge thing. That again brings back to us, like, what is a healthy weight loss? Yes, we are using a BMI, but are we going to bring them to a BMI of 25 from where they are, which we call an ideal weight? Are we expecting to lose a little bit of weight so that they become metabolically healthy? So if we look at studies, if we look at the data that's available, 5 to 7% of weight loss from where you are right now is good enough, has been good enough. So when they compared even drugs and just lifestyle, if you lifestyle to bring down the weight by 7%, it was much, much, much more efficient even than drug therapy for preventing somebody from becoming a pre-diabetic to a diabetic. And so definitely, so 5 to 7% weight loss for prevention of diabetes, about the same weight loss, 5% weight loss to bring down your blood pressure by about 8 millimeters mercury, and about 10 to 15%. So when you consider a fatty liver regression, for example, you need a little bit more weight loss to keep your. So if you can help them understand that being metabolically healthy is more important than the actual weight loss itself, and what it can do to lose that little bit more weight, what it can do to their metabolic health, I think that is a good place to start with, to educate them on. And also the other big thing when it comes to the long haul of obesity treatment is people who are going to lose their weight should have a realistic expectation that there's going to be a plateau, right? Like they can work on losing weight, but at some point, I wanted to show this. So let me see if I can share my screen. You all see this? So this is called, like, we all have a fat mass set point, which our body is trying to defend, right? So for an obese patient, their set point is different. Their set point is higher than a normal patient. So what a person with a normal BMI is defending their fat mass, but a person with obesity is defending the new set point of the fat mass. So you're going to have stronger responses when you start to lose weight to bring you back to that set point, to reset that set. So what do you mean? It's like a rubber band phenomenon, like it showed here. So because of the body mass index, the fat mass index is set at a different level. The longer you go from that, the stronger the pull is going to be, like a rubber band, right? Like the more you lose weight, the more you are going to start feel hungry. Your body is going to work against you, even though you do all the things that you do, because you have a different set point and your body is going to defend that set point. You're going to have more ghrelin, you're going to have more leptin, all the hormones involved. So you are working on resetting the set point. It has been proven in studies that when you consistently work on weight loss, you are able to reset that set point at a different level. But we may not be able to change it too much. So we have to have a realistic expectation of how much weight you're going to lose. And second, you're going to have a realistic expectation that there's going to be a plateau where you're going to settle down. You're not going to lose more and more and more to come to a normal weight. And there is going to be a realistic expectation that if you do not persist on the efforts to maintain the lost weight, there is going to be a slow regain of your weight, what you have lost. So all of those things need to be explained to the patient so that they have some realistic view of what obesity management looks like.
I think well said. And then, as you said, it's very important upfront before we even initiate a treatment. We sit down, chart to them what is that is suitable for them to achieve, and what is beneficial to them, and what would happen during the course of treatment. I think these are very important points that we need to reiterate to the patients at the beginning. At about 5% weight loss, what you suggested, we are going to see improvement in uh, some or most of the metabolic comorbidities as highlighted in the diabetes prevention study. And greater the weight loss, like 5 to 15%, we are going to even more see a lot more improvements in many other comorbidities, including having a mortality benefit. So I think in terms of the weight loss that we want to achieve, it should range somewhere between this at least. Weight gain is going to be a problem if they are not going to adhere with this advice over the long haul. And secondly, weight plateau, for sure, everybody hits it at some point of time, unless they take additional measures to overcome this weight plateau. So these things are very, very important. The goals need to be set. The goals need to be realistic. And that's better if it's set early in the disease course. So
The fat loss
halfway
is
through the treatment.
the fat loss is actually more important than the weight loss. The first to go or first to get born is the metabolically active visceral fat. That's the reason we are getting they are getting metabolically healthy actually. So increasing the lean body mass actually increases the resting metabolic rate, which is more important. Whenever the resting metabolic rate increases, which is the major, which contributes to the major portion of the total energy expenditure, they are going to have a very good metabolic profile and sustained weight loss as well.
Yeah, so the goal certainly is not just about achieving weight loss. It's about achieving good weight loss, achieving safer weight loss, and the weight loss that is enough for them to see improvement in comorbidities. Again, it would be great if Padma is around to discuss about what would be the ideal fat mass percentage for male and female, and what should be the target that we need to achieve. Like what they suggest is in females, as long as it's around 20 to 25%, that's the goal that we need to head to. And in men, between 15 to 20% is a rough goal that we need to head to. I think these are some of the additional parameters which we need to use to kind of like say how successful our treatment options are. And one other thing is, it is inevitable that during this process of losing the excess fat, the patients are also going to lose muscle mass. And it is very important that we prevent our patients from having excessive protein breakdown, excessive muscle mass, wherein physical activity and training comes more important. We need a physiatrist or a therapist who needs to give these patients an exercise plan to make sure that they don't have a muscle mass loss in excessive amounts during this weight loss journey.
Yes, very well said. Yeah, definitely. Like, we don't want to starve them and make them lose their muscle. Definitely. So that's where the exercise prescription plays a huge role. Like, I wish Padma is here to talk more on that. But so we all come from different places. I want to know a little bit more about like what each of your experience is. Like how much, when you see your patients, how much do you think that the diet and exercise itself is contributory to this problem versus there's more to it?
For me, diet is the primary factor, maybe more than 80%. and exercise plays a minor role actually, because the concept of gym and fitness doesn't exist before 1970s and 80s, right? So actually what we eat is more important, as well as the regular physical activity is very much important as well. But the primary factor being the food we eat.
I think in my practice, like there are several contributing factors. Like I have a mix of Singapore is like very multiracial, so we have a mix of population, including Caucasians, South Asians, Chinese, and Southeast Asians. So all of them come with different levels of fat distribution. And the obesity prevalence is also grossly different in different subsects of the population. More than that, the society by itself is very fast paced. So there is going to be a lot of stress and emotional factors which contribute significantly in putting them at risk of developing diabetes or obesity or whatever that metabolic syndrome it is. So in case of we approach these group of patients, again we have to go to our learning board to identify what is the important factor that is predisposing them to develop obesity. It could be just poor diet management, poor sleep management, stress factors, and sometimes it's a strong family history, childhood obesity, and so on. Because as we know, somebody who is obese during childhood, they're going to carry it towards their adulthood, and sometimes it continues. In terms of the like pure genetic causes, like people talking about leptin deficiency or melanocortin issues, those are something infrequent that we see in practice. Most of the time, uh, the reason for obesity is sedentary lifestyle or poor choice of food or stress and so on. So then our approach is tailored towards addressing the underlying root cause. It's hard. It's very hard. It's not an easy journey for everybody to do it. But one important thing is small, simple, sustained changes to begin with is what is going to give them the confidence to pursue. As long as they see some initial weight loss with simple changes that they can employ in their everyday life, that motivates them to pursue more and more and more. Once they start seeing benefits from the weight loss that they have achieved, then they are going to be persistent. So it all depends upon how we identify and work together with the patient. Diet certainly, yes, plays a crucial role in terms of inducing weight loss. And as we all know, there are different kind of diets, and some of them have commercial interests, and there are like this industry is huge. So there are like a lot of advertisements of and the obesity treatment also comes with a big financial package to the patients. It's not like easy. They end up spending a lot trying to do like take in different type of treatments before they actually see you. So we also have to be a little bit cost conscious in terms of what we deliver, because by the time they come and see us, they have already spent a lot more. So we take into account their prior efforts. We sit down with them, identify what all that we can modify. We work together with a group of people with expertise in different areas, and then we come up with a plan. One of the most important thing that we inform this group of patients is, once we give a plan to you, you have to come and see us whether it is working or not working. If you don't come and see us after the first one or two visits, there is no way that we can identify which works and which doesn't work. It's like somebody with a cancer goes to see an oncologist. If the first drug doesn't work, the patient still goes to the same oncologist to identify what works for them. But in terms of obesity care, the patients don't take it that way. If one works, please come and bother us. Please come and tell us why this is not working. Then we can figure out the next way to help you out in terms of achieving your goals. So one thing which from the patient side that they need to remember is you need to adhere to the follow-ups. So we know what works, what's not working, and we can customize the plan. And diet and exercise certainly is a backbone. There is nothing that is like a miracle pill or magic treatment in obesity care. The foundation for obesity management is going to be around diet and exercise, and all other treatments are adjuncts to facilitate diet and exercise easier. So this is how we approach obesity care in our unit.
Yeah, very well said. Again, the macronutrient composition is very much important because the traditional Western diet is having a very low carbohydrate and rich in fats. I mean healthy fats, not the refined one. Whereas our traditional way of eating is increased complex carbohydrates and little amount of fats. What happens with this is decreased insulin response with these kinds of food. What we take nowadays is ultra-processed food that is having refined grains, refined fat as well. In the presence of insulin, what happens is that the carbohydrates burns, but the fat gets added onto the adipose tissue. This is what happens. So we need to move on to the traditional way of diet, moving away from the ultra-processed food. Okay. And we need to address to each patient in an individualized way. We need to know their personal fat threshold. So it's very important. The personal fat threshold is nothing but how well they can increase their fat mass without becoming metabolically unhealthy.
Okay. It's very similar to what Ravi said in my practice, because I serve a predominantly African American population, and they come from very bad social situations. So they have extreme stress in their life. Many of them have a lot of food insecurity. So even if you tell them to cut down on the processed food, they have no way to cut down on the processed food because that's all is available for them. And then most of them don't even know how to cook. And they don't exercise at all. Like they are stuck in front of their screens playing video games, or it's a very, very tough situation that we try to fight as we treat obesity in the population that I serve. So definitely diet, exercise is a huge part, but the social stress and the food insecurity that we go through is also a huge part of obesity prevalence, as well as the struggles in the treatment. So there is a lot to it. And Ravi, you brought up a good point about history, right? Like history is so important. When we talk to the patient for the first time, right? When did this become a problem, right? Like when did obesity become a problem? You may be able to identify big chunks in their life, which was the main reason why they became obese. You know, like my wife died, I started carry out since then, and then I've been like this. Or they may come up with things like we moved, you know, like when you identify big things in their life. And also a lot of genetic carryover from the parental side is definitely obesity is a genetic problem. It's not just an environmental problem. So we have to factor that into account. And we have to tell people that it's a disease, right? Like a lot of them see excess weight as something cosmetic. It is more than that. We have to get people to understand that it is a disease. When they understand that it is actually a disease, then it might be more easier for them to actually do that real follow-up that we want them to do. Otherwise, the follow-ups are going to be not easy, because if they think that it's just a cosmetic problem, and for them If it is a cosmetic problem, they need immediate results. And if the immediate result doesn't work out, they're not going to come for follow-up. But when they understand that it is a disease which has much, much, much more implications than cosmesis aspect, then they will stick to the treatment. So I think that's a good discussion for the first time. If anyone had anything in addition, we can do that. Otherwise, we can wind up and we'll come again and we'll dive deeper into the specific kinds of diet, the macronutrients. Probably the next time we'll do a lot more on the diet and exercise aspect so that we can get into the nitty-gritties of it.
Yeah, the disease of the plague of prosperity, that is obesity, is now disease of the poor and the downtrodden because of the change in the food policies. So we need to have a very good policymakers as well.
Yes. Yes.
At the population level.
Correct.
I think what Kavya concluded is very important. Obesity is a disease. There is no reason why we should not say this to our patients when they have obesity and associated comorbidities. In different communities, there are practices or even beliefs wherein they consider excess weight as healthy. This is why predominant in Asian African American communities, where a slightly an obese phenotype is actually considered as healthy rather than being on the healthier weight. So these things need to be highlighted. More awareness need to be created among our public, and it is the right time, like having one pandemic which has already taught us, saying that patients with obesity are at risk of dying because of COVID. There is no better time than now for us to bring this to public attention, saying obesity is a disease, seek treatment early, and there are options to help you. It's not like the past. There are a lot of options now to help you get back to your old state. And I think this needs to be repeatedly said, emphasized, projected in media multiple times until patients find it easy to come and consult physicians to seek treatment rather than staying in their own silos.
Yes, agree.
We all have different perspectives to the disease, and we work together in a more progressive way to enlighten the public as well.
Okay. See you all soon again.